I'll start with this slide. I've been giving anesthesia for almost 30 years, I should say, from AIMS days from 1993. And almost 6 or 7 years ago, when I was getting into the field of mindfulness personally for myself to learn meditation and do it, that's when I started wondering, how does actually anesthesia work? And what do we do there? And what is the correlate? How does it correspond to the mindfulness states that people attain when they meditate? So I really didn't have any clue about that. And I was fortunate enough to interact with Sadhguru, and I did ask him this question. He basically said, anesthesia can only take away memory, it cannot touch consciousness. That kind of put me in this path of whatever I am on, because that blew me away. And I don't think I fully grasped what he has said so far, but let's see where this journey takes me there. So now just looking at this from the scientific point of view, Christoph Koch, who is a chief scientist and president of the Allen Institute for Brain Science in Seattle, he has been prolific in his publications, and so is another speaker in our panel. He basically talks about how does this 3-pound organ with a consistency of tofu exudes the feeling of life? That just tells you what all you need to know. And that is a question that we have been asking ourselves. Is brain a window, or is brain the responsible organ for the consciousness piece? I don't know whether we know the answer yet for that particular question. So when you look at brain, just morphologically, you have frontal lobe, parietal lobe, temporal lobe, occipital lobe, and cerebellum, and spinal cord. As anesthesiologists, we do regional anesthesia, so we give a lot of medications in the spinal cord. We have seen patients with cervical spine injury, and we know that spinal cord is responsible for the immobility piece of anesthesia. So what are the features that we need to have in anesthesia? We basically have to have amnesia, which is basically you forget what happened at that time, and loss of consciousness, so they can facilitate the surgery to happen. And finally, immobility. And analgesia is a piece that is actually facilitated by other medications, but anesthesia itself can only offer a little bit of analgesia, not entirely. So when you lose the spinal cord aspects, you end up losing, having immobility. It is not risk, but still the patients are conscious. So recently we had a patient who was a 67-year-old orthopedic surgeon. He was riding a bike and he hit a stone when he was riding a bike. So here the cycle is called a bike in this part of the world. And he fell and had a cervical spine injury. He was fully conscious, but he couldn't do anything. It was a week after, and they determined that he was going to be quadriplegic for his life. So all that he had was his brain and the consciousness. I still remember that he declared that he didn't want to live after that. And so he basically begged people just to take away his life and end his life. And that has touched me so much and so deeply. His wishes were honored, but that tells you that you still are fully conscious, but immobility is a huge problem, and especially for a learned man like that to make his own decisions. So let's just move to cerebellum. And cerebellum, the common example that people give is, you need cerebellum for coordination and motor activity, especially, for example, piano playing, right? But if you lose cerebellum, or if you have cerebellar diseases or cerebellar injury, you still can have consciousness. So that is not the place where it is originating from. So let's move on to the frontal lobe. There are several people with frontal lobe injuries. As trauma anesthesiologists, we have seen people with frontal lobe injuries. We have seen them in the intensive care units. They still have the consciousness content in them. So frontal lobe is not probably where the consciousness is coming from. So I'm sure people have dwelled about what is consciousness. It is not just being aware of where I am, my circumstances, but it's also the content. Only the person who experiences can express that. So I don't know how many people with a frontal lobe injury can express it, but it is at least clear that people with frontal lobe injuries can still have consciousness. So perhaps consciousness is coming from this part of the brain, which is parietal lobe, temporal lobe, and occipital lobe. And there is also a way to measure it. They're coming out with, exciting these portions, complexities, neural excitations, and with a magnetic pulse, and yielding a measure of the degree to which a person is conscious. If that develops and can actually become a meter to tell us what consciousness is, that'll be awesome. So I think there are many scientists who are working on this area. we just, so they use anesthesia, sleep, and disorders of consciousness to understand and indirectly interpret what consciousness is from this end of the spectrum. So one aspect of all these things, especially what Sadhguru told me, that it only can take away memory, impressed me because of this particular slide. The incidence of awareness during anesthesia. So as late as 10 years ago, a study that was done within the United States and about many hospitals that collaborated with it, the incidence of awareness seems to be around 0.13%, which means that 1 to 2 patients out of 1,000 patients can have this awareness. So what does it mean? That they can actually recall exactly what happened, at least during a period of anesthesia. So that, when I look at it, it can take away memory, probably does not done a good job in taking away the memory piece. And so they have remembrance of some of this. So there is explicit awareness, there is implicit awareness. And that actually makes me think that maybe Sadhguru is right when he says that, it can only take away the memory, but not consciousness. Now, how does anesthesia bring unconsciousness, right? And initially, when 19th century, Claude Bernard started with his unitary hypothesis that, there's probably final common pathway. There's one portion of the brain that is responsible for the loss of consciousness, and anesthetic drugs go and act there. Mayer Overton improved on it, and he said all these anesthetic drugs are lipophilic. And when they are lipophilic, they can disrupt the membranes. When they disrupt the membrane, the conduction of the electric current is disrupted, and so that ends up being an anesthetic state. But we all know that there are several anesthetic drugs that are not lipophilic, but they can cause unconsciousness. There are also temperature, which can disrupt the membranes, but does not cause unconsciousness. So that theory is probably not really great and elegant because it cannot explain these problems. So we talked about the immobility, amnesia, and absence of awareness. There seems to be that there's a dose-dependent response on these 3 actions. You can have immobility, you can have amnesia, you can have absence of awareness, not all of them together. So there's a dose-dependent response that is required to produce this unconsciousness and amnesia. And there are also molecular mechanisms to explain that. Inhaled anesthetics probably act directly on the spinal cord to produce immobility. So probably the anesthetics are not acting in one area to produce the state that we're talking about. So this picture explains to you that people with no response, typically, clinically, as anesthesiologists, we describe that if I give anesthetic, there shouldn't be any response. And that's all surgeon cares about, right? So he can operate on the patient without patient responding, without patient experiencing anything that he does. So he can go ahead and cut. For example, in cardiac surgery, the only reason why they give cardioplegia and arrest the heart is because the heart stops and surgeon can take the sutures really well. Whereas in India, they do it on the beating heart. So things vary. Anesthesia can cause different things, effect on the explicit memory, effect on the perceptive awareness, movement in response to pain, and autonomic reactions. Everything is different, and the neuronal networks influence behavior remains unknown still. So there's no single receptor to explain all these things. Memory can be blocked at levels that does not suppress awareness still. So you can have actions at different dose responses. And effects of anesthetics on episodic memory is possibly through suppression of dorsolateral prefrontal cortex. We talked about why frontal lobe is not probably the area responsible for loss of awareness or unconsciousness. And we really don't know how the anesthetic effects act on implicit memory. And even in the absence of consciousness, implicit memory can be formed. And there are several papers that have talked about how you can teach people to learn some things under anesthesia. So all this theory on Mayer-Overton rule and the unitary hypothesis doesn't seem to explain everything, and the dose dependence doesn't seem to explain everything. So let's just look at the ion channels at the fundamental level. So now we as anesthesiologists, everybody asks, how does anesthesia produce unconsciousness? Everybody says, oh, it acts on GABA channels and produces it. Okay, so what? It acts on GABA channels, and then what does it do? We have to take from that step to the next step. So it seems like it regulates synaptic transmission and membrane potentials. When you potentiate GABA, it is an inhibitory effect. So when it inhibits, so probably awareness of all the impulses that is coming from the spinal cord, that is a feed forward impulses, is basically not interpreted. And so you probably end up in the state of unconsciousness. The second most important thing is NMDA receptors. NMDA receptors are the excitatory neurotransmitters, and ketamine is a drug that is supposed to act on these and produce that excitation. So you can have loss of consciousness in an excitatory state as well. Ketamine is your example because it produces the EEG changes at the gamma level, and it can do that. Potassium channels, maybe, maybe not. And then you have acetylcholine, which can be another important channel by which it can produce. Then you have AMPA channels. Now, so it acts on these GABA, increases the flow of chloride ions, and then blocks all these transmitter-gated receptors and prevents the influx of these feed-forward impulses and probably stops the awareness of all the impulses that is coming from. So when an anesthetic is given in a dose that is adequate for sedation, first thing that you feel is drunkenness, like distorted time perception, depersonalization, sleepiness, and amnesia. We are all aware of this. There's a loss of inhibition, and people actually start talking things they never thought. For example, when my wife had anesthetic 20 years ago in Ames, there was the first time I was hand-holding where somebody else was giving anesthetic. I got to know exactly what she thinks about me at this dose of sedation when the anesthesiast started to give. So neurons oscillate between a depolarized up state and hyperpolarized down state. And slowly the down state becomes dominant. And then you go on to the state of deep sleep, and then probably the EEG states of bus suppression, which is what happens with the higher doses of anesthetics, wherein the patient actually fails to move in response to command, which is a classic definition of anesthesia, which every clinician understands. And there is also a dream state that happens wherein there's vivid conscious experiences. The patient may be unresponsive, right? So, but you can have the conscious experiences. So whether it is unconsciousness or unresponsive, you can have either state independent of each other. So that is what I'm trying to impress upon here. In dream state, you are having conscious experiences, but you're unresponsive because your brainstem is inhibited, and that leads to muscle paralysis. Paralyzing agents, which is a gross example where you don't remove unconsciousness, but you actually make the patient unresponsive. So you can have these unconsciousness and unresponsiveness independent of each other. Individual anesthetics and their cumulative actions on the brain and spinal cord. So because we're talking about the ion channels, and next is action act. So here you can see the cerebral cortex, and the common drug that is currently used is propofol, and seems to act both on the frontal as well as the parietal regions. And when it acts on these inhibitory interneurons, this orange color structure, it prevents the influx of this major acetylcholine input from the locus ceruleus, pedunculopontine tegmental nucleus, lateral dorsal tegmental nucleus. And it also prevents the orexin, which is responsible for sleep. Orexin antagonists are used for promoting sleep. And ventral tegmental area, which produces dopamine. And then you have acetylcholine that comes from the basal forebrain, that is the hypothalamus. All these inputs are actually inhibited by the propofol. And this picture was adapted by one of our scientific advisory board members, Emery Brown's work from MIT. Now, when you look at dexmedetomidine, it acts at the basal part of the brain. We just talked about the cortex, whereas dexmedetomidine is the basal part of the brain. And it is one drug of all the sedatives that mimics the natural sleep. So when it acts as an alpha-2 agonist, and it acts at the level of the ventrolateral preoptic nucleus, we're all aware of what is the importance of this for the sleep portions, tuberomammillary nucleus and locus ceruleus. And that is where dexmedetomidine acts as the basal part of the brain. When you take opioids never really cause complete unconsciousness. At the best, it can cause maybe 60% of the effects, but not more than that. But it does block all the feed-forward painful impulses that comes from the spinal cord. At the level of the spinal cord, it can act. It can act at the level of the rostral ventral medulla, and at the level of the pons, and then you can act at the level of the thalamus. So it can have multiple effects in various agents. These are the commonly used drugs in anesthesia. Now, EEG characteristics of anesthetic states, we just talked about, again, adapted by from Emery Brown's work. When awake with eyes open, you see this low amplitude, high frequency EEG. When they close the eyes, as soon as they close the eyes, minimally conscious state, you can have low frequency, slightly high amplitude. You can have paradoxical excitation. This can be explained. Actually, Emery elegantly describes about this in his New England Journal of Medicine, why somebody, as soon as you start inducing a patient, goes into this paradoxical excitation because of the thalamus inhibitory input on the cortex is released. When that happens, you get into excitation states. We have seen many times that when you start giving the medications, before they go into full anesthesia, they start moving a lot. So having these patients, the twilight zone is not really great. And many of us will agree as anesthesiologists. Then you go to this phase 1, phase 2 vegetative coma states, bus suppression, and isoelectric states. You can have similar EEG patterns in the sleep states, which basically talks about how general anesthesia, sleep, and coma can have similar EEG features. Now, moving on to the cellular mechanisms of conscious processing. So all this is great, we know the ion channels, we know where it works, but how does actually produces the experience? That is, we have this unconsciousness. How does it produce this unifying experience that person? This is a recent theory which talks about dendritic integration theory. These are highly, specialized neurons which are sitting in the layer 5 of your cortex and layer 5P. And when you look at these dendrites, you can have these apical dendrites, you can have this basal dendrites, and you have this intermediate zone, otherwise known as a coupling zone. So there is a lot of feed-forward input that comes into this apical dendrite, which is context-specific, and you can have this NMDA spikes because they're excitatory, whereas the higher order input is also coming into this basal dendrites. And this information needs to be coupled in this particular zone in order to get this unifying experience. So they're saying you can have drugs acting in the frontal lobe, parietal lobe, temporal lobe, wherever, but you have to understand that this coupling portion is important, and that can probably explain, how we eventually end up in this unconsciousness state. So we talked about how Christoph Koch talks about this posterior part of the brain is responsible for unconsciousness, and this global neuronal theory, which talks about this entire brain is somehow aware of this conscious process. So any information is one part of the brain is transmitted to another part. But when you take this dendritic integration theory, this kind of cells can be in any part of this brain. And when you have this anesthetic which is given, they probably block this portion which is responsible for integrating these two. When that happens, the feedback and the feed forward is completely disconnected. When that disconnect happens, you end up having unconsciousness. And Emery quotes this as like a Seattle-Tacoma Washington bridge, which is basically a very, very long bridge. And when this kind of block happens, it is undulating like that. Like in a wind, when the bridge is undulating, no one can pass through. So similarly, information cannot pass because of this blockage that happens. And you can see how there is crosstalk between many, many areas, thalamus and to the cortex. And then you actually see that this information that comes into the thalamus, it doesn't go into the cortex portion. So corticothalamic, corticocortical connections are basically lost because of this anesthetic drugs. Now let's just talk about the importance of thalamus, right? When you look at the thalamus, it's situated right here. This is a cross section, and you can see in this full imagery, anterior cingulate cortex, posterior cingulate cortex, the mesial parietal cortex, and the basal ganglia right there. And it seems like thalamus is responsible for everything. When you give GABAergic drugs into the thalamus, it seems like people can go into sleep right away. When you give nicotine, it seems like it stimulates the patient and they come out of the sleep states. And that is some of the work by Nicholas Skiff of stimulating patients in minimally conscious states using the thalamic stimulators. And when there's a midline thalamic damage because of any brain injury, etc., you lose consciousness. So is that enough to explain that thalamus is one of the main reasons why patients are conscious? So there are some elegant experiments done with thalamic and cortical ablations. When thalamus is ablated, it seems like when you give anesthesia, cortical EEG can be there and you can see the EEG state. So that doesn't seem right. Then when you have cortical ablations, but this you cannot produce the anesthetic states. So it seems like cortex an important piece, but thalamus may not be. And basically it may be a readout of what is happening in the cortex. So whatever is happening in the cortex, thalamus reads it out. And that's what is seen in the elegant deep brain stimulator experiments. When they come in for second surgery after the brain stimulator is implanted, you can actually see that when patients go under anesthesia, you can actually track this EEG, and it supports this concept of cortical readout. And you can have functional thalamic deactivation. When thalamus is not interacting, you can have cortical and corticothalamic connections or slowed down, and because of that you have loss of information processing, right? We can also, I think we talked about this, variable effects on the frontal cortex. Thiopental acts mostly in the posterior, propofol acts in the anterior and the posterior portions of the brain. So that is a little different in the way these drugs act. And we also talked about the importance of the frontal cortex. So let's just skip this slide and go into the final common target. And I talked with the Christoph Koch slide early on that the temporoparieto-occipital junction may be the final common target, and maybe the mesial cortical core, which is responsible for the anesthetic-induced unconsciousness. So all this is great. Now, we also talked about the dendritic integration theory, but let's just expand on that a little bit and see what happens to the integration piece, disruption of the cortical integration piece. They talk about this DICE, and when you have this loss of cortical integration because of an anesthetic, it seems like all these components just breaks into smaller pieces. And when they break in, and you can see here, the frontal lobe, occipital lobe, and parietal lobe, the red portion is where the information is going from each of these, and green portion is going in the opposite direction. That's your feed forward and feedback phenomena. Whereas with the anesthetic, the information that's coming from below, that's a feed forward information is great, but the feedback information coming from the frontal lobe to the occipital or to the parietal lobe, which is reverberation and important of maintaining the consciousness, is minimized, or is it lost with the anesthesia and loss of cortical integration. So another example is when you give a stimulus, it goes in a purposeful manner and it spreads from one side to the other side, whereas with the same stimulus under anesthetic states, it's like a general local spread, and that tells you that integration is lost and it's just locally spreading. And you just need to disrupt only a few long-range connections and to produce this set of disconnected components. And the next portion of the same extension is cortical information capacity. So here, it's not falling into individual pieces, but it just becomes a two-dimensional, then so the information capacity that it can hold is also reduced. So that may be another way that the problem is done. Then we talked about, okay, all these are mechanisms of action, but how do you experience, right? So George Mashour from University of Michigan has been doing some elegant experiments and with Hudetz, and they've shown the observed division of labor and the unified experience. So that's called the cognitive binding problem. So one way to overcome this binding by convergence, maybe there are a set of neurons that have been assigned to do a particular job.
Can I interrupt you? You have 2 more minutes.
Yeah, okay. I'm at the end of the slide.
Yes.
So that probably explains, but what happens when a new information comes? Binding by assembly. Maybe every information, there's a recruitment of these neurons and you get into newer assembly for every piece of information that comes in. Or binding by synchrony. This is the orchestra example where there are individual members for different states. During the temporal association, you can get into the binding, addressing the binding problem. So maybe anesthesia acts by cognitive unbinding of this process, and that's why it leads to unconsciousness, right? So it's not an all or none property. It is graded. So you can have dimming or the field of consciousness, and Sadhguru talks about, increasing consciousness should be the common thing that we should all attempt towards. So again, that explains what increasing consciousness means. Now, the questions that I have for the following speakers or Dr. Bindu's group is, what happens during stillness, which is the meditative aspects? Because we talked about all this unconsciousness and disorders of consciousness and anesthesia and sleep. And do I know my brain only through my thoughts? So where are the thoughts originating from? when everything goes silent, what do you feel? Because we always talk about this information coming in, the feed forward, but when there's no information coming in deep meditative states, how do you actually have consciousness? And the yogic descriptions talks about Jagriti, which is wakefulness, which is what I think we have been talking so far. We don't really talk about the other states like vivid state, dreamless states, or the Surya states. So I'll just skip this slide, and thank you very much for this opportunity. I really look forward to other speakers and learning from you all. Thank you once again.
Thank you, Dr. Bala, for that wonderful lucid presentation on the consciousness under anesthesia. You have briefly touched upon the entire brain dynamics during anesthesia. From cellular mechanism to the system level and to the cortical integration. So beautiful. I'm sure that you will be a great teacher. Really, we really enjoyed your talk.
Thank you.
And also taking us from that basic to little bit connection to philosophy. I think that we will have a discussion, during that discussion, we will discuss that. So thank you so much. Please stay on. We will have the discussion Q&A after everybody speaks. Now, it's my great pleasure to invite Dr. Stephen Loris, Professor, Department of Neurology and Coma Science Group, University of Liege, Belgium. He will be talking on the topic, the neurology of consciousness, lessons from a coma and related states. I will just briefly share with you his brief biodata. Dr. Loris is a research director at the Belgium Fund of Scientific Research, director of Giga Consciousness Research Unit and Coma Science Group at the University of Liege, Belgium, and joined International Research Unit on Consciousness Servo Brain Research Center in Canada. Dr. Loris is recognized worldwide for his clinical and scientific studies on the neurobiology of consciousness. With his team, he explores the human mind in health and disease using brain imaging technologies, assessing coma, near-death experiences, concussion, anesthesia, hypnosis, and meditation. He has authored over 500 scientific papers with a whopping H-index of more than 120, and has published several books, including The Neurology of Consciousness, and popular books, including international bestseller, The No-Nonsense Meditation Book, in collaboration with Buddhist monk Matthew Richard. Stephen has been elected fellow of the European Academy of Neurology and Belgium Royal Academy of Medicine, and is past president of the Association for Scientific Studies of Consciousness. Professor Loris is also a defender of animal well-being and co-initiator and signee of the Cambridge Declaration on Consciousness. Over to Dr. Stephen Loris, and I welcome you to deliver your talk on neurology of consciousness, lessons from coma and related states. And as you know, your time is for 25 minutes. Over to Steve.
Thank you. Thank you so much, Dr. Bindu. It's a pleasure to be here with our friends in India. And of course, I also need to mention that thanks to you, we have the pleasure to host Rajanikant Panda as a PhD student in our lab. As you mentioned, I work in Belgium, but actually now speak from Canada, where I'm working on this international laboratory on consciousness, where with the different teams over the past 25 years, we basically tried to answer Dr. Bala's very challenging questions. How can something material as the human brain, and I'm holding one right here, can give rise to thoughts, perceptions, emotions? And the answer is, we don't know. It truly is something where, as scientists, we should probably remain humble. We don't know whether we have understood 50% of the question, or 5%, or 0.005%. So it's really very, very difficult and yet terribly important. Of course, as a neurologist, when I'm confronted to patients, you see our intensive care unit, it is clear that consciousness matters. So we just had a wonderful overview of how we can lose consciousness in anesthesia, which is pharmacological coma, by Bala Subramaniam, and we will hear more about that by Sri Ganesh Kamath later. We also know and actually use in our hospital the power of the mind in, for example, hypnosis. And we're very fortunate to have the team of Dr. Bhaskar Vyas on that subject. I will focus here on pathological impaired consciousness, coma and related states, where it's very frustrated as a medical doctor trying to answer the very difficult question, is this patient conscious? Well, how can I measure that? I'm basically making inferences based on a motor response. We just heard it from Dr. Bala. It's very frustrating also in anesthesiology, and that is why there is so much added value from all modern neuroimaging techniques. And we will basically use all of the machines you see on this slide to try and reduce the uncertainty. And I think it's useful maybe to try and define what we're talking about. What is consciousness? As said, we basically don't have a clue. We don't agree on its definition, and yet clinically we need operational definitions. And consciousness, I think, can be seen as having two main components. It's what you see here. There's the level of consciousness, which is wakefulness. And that is what you see every time you fall asleep happen, when your level of wakefulness decreases up to the point where you lose awareness of your surroundings and of yourself. Already there's this notorious exception, which is REM sleep, lucid dreaming, and the same actually in general anesthesia, and these dreamlike states we just heard about by Dr. Bala. And then there's coma, where there is a traumatic injury to the brain or hemorrhage or lack of oxygen, and the patient by definition will no longer show signs of wakefulness. Even when we would stimulate auditorily or with painful stimuli, the patient will never open the eyes, which is how we measure at the bedside wakefulness. And then something very bizarre was observed in the 70s when we had intensive care and these artifacts of modern medicine, people surviving their coma, opening their eyes, but yet showing only reflex movements. And that was coined persistent vegetative state. I prefer to use the newer term, which is unresponsive wakefulness syndrome, because it's neutral. We don't want to compare patients to vegetables, and it's basically descriptive. It's a patient who looks awake, eyes wide open, but is not responsive to external commands, which is what is the topic of today, minimally conscious state. Maybe we should say minimally responsive state, which is more correct, because again, at the bedside, we make inferences based on motor responses, and that is for minimally conscious state plus a patient who would sometimes answer a simple command, like squeeze my hand. Minimally conscious state minus would be a patient who would show some non-reflex behaviors, such as orienting to pain, or following with the eyes, or smiling when there's a family member in the room. You can't say it's reflex, but that's all you have. Very, very frustrating. You know that these patients sometimes are a little bit conscious, but by definition, you can't access that because they can't communicate in any way, verbally or non-verbally, through a yes-no code, as is, for example, the case for locked-in syndrome. You know, when there's a lesion in the brainstem cutting the motor fibers, you get an isolated mind and brain, unable to control the muscles in the arms, the legs, the face, and so it is locked in a paralyzed body. And for neuroanatomical reasons, classically, only the eye movements permit them to establish a yes-no code. So just as we've reduced consciousness into two main components, wakefulness or the level, awareness or the content, I propose to do the same with awareness. external awareness and internal awareness. And it seems to be the case, if I would summarize the past 25 years of research from coma and related states, but also anesthesia and hypnosis, it's that you have these two components with their respective functional neuroanatomy that overlaps with the global neuronal workspace theory of Bernard Bars. In red, you see critical areas for external awareness, and these are frontotemporal associative areas, both hemispheres. That is important for you to see, to hear everything coming through your senses. And then there's the rest, which is internal awareness, permitting you to think right now, the little voice in your head, anticipate the future, reflect on your past, overlapping with the default mode network. Internal, or if you want, self-awareness networks are midline, mesiofrontal, anterior cingulate, posterior cingulate, precuneus. These are the critical hubs. And when we started, it was not clear whether consciousness was just some global function depending on overall metabolic activity in the brain. So with positive emission tomography and a brilliant team, we could show that if your brain is at full 100% when you're awake and aware, things look very different after brain death. When there is no more activity in the billions of nerve cells, you see here, it's the empty skull sign. Only the skin shows some metabolic activity. During sleep, we again see a massive global decrease. In REM sleep, we see something paradoxical. Overall glucose metabolism very close to normal waking values. During general anesthesia, we again see, for most anesthetics, a massive global reduction. And of course, when you stop the anesthetic, you return to normal consciousness and full 100% brain activity. So you could say consciousness is just, or awareness, a threshold thing, but it isn't. And that was what we understood by looking in coma and unresponsive wakefulness, previously coined vegetative patients, where again we see this massive global cortical reduction. But when they recover, they don't recover full 100% in the whole brain. In other words, there is a specific network that is more critical for the emergence of awareness. You see it here. In another way, of course, there are differences between unresponsive or comatose and minimally conscious, and those who emerge from minimally conscious state when they can again functionally communicate and healthy controls. But there's a lot of overlap when we just look at global metabolic activity. What seems to be more informative is quantify the functional integrity in this frontoparietal external and internal awareness networks, which we also see impaired in absent seizures, complex partial seizures, sleepwalking, and where we now, of course, have the tools to go further, not just even look at connectivity changes, but the directionality of these connections with what is called dynamic causal modeling, where you see here a high-density EEG study with auditory evoked potentials, and you see that there is this top-down feedback connection, the red arrow, that was only observed in patients who were conscious or minimally conscious and not when they're comatose, vegetative, or what we now say unresponsive. We also try to understand how patients in minimally conscious state are typically fluctuating. It's very frustrating. When I would examine a patient, I would see nothing. He wouldn't answer a simple command, for example, and then I would come back an hour later or the next day and he would do it. So how is it possible that on top of the classical sleep-wake circadian rhythms, we see these ultradian rhythms that are characteristic, I would say, of minimally conscious state after the injured brain? And we tried with long-duration EEG measures to capture those temporal windows. And with a simple measure that is entropy of the EEG signal, we show here that minimally conscious state patients have every 70 minutes, it seems, this increase in entropy that may be of importance for us to do the clinical assessment, but also to apply our treatments. Now, we can also couple EEG to a technique called TMS, which is transcranial magnetic stimulation, that permits us to perturb the brain at a specific point of the cortex and then read out the electrical echo. And we, with our colleagues in Italy and the States, with Giulio Tononi, who proposed integrated information theory, developed a test. This was done by Marcello Massimini, who proposed what we call perturbational complexity index. It's very ambitious. It's reducing consciousness to one number, from 0 to 1. And if the complexity of the EEG signal after the TMS perturbation is below 0.3, patients were in deep sleep, in anesthetized, comatose, unresponsive. It was higher, they were healthy controls, locked in, and minimally conscious were in between. So very interesting to again challenge our theories with real data. We just heard a wonderful overview by Dr. Bala of how anesthesia impacts the brain, and we are very far from understanding the mechanisms there, but it seems to be the case that what is important is this thalamocortical dynamics with what you see here, the internal awareness that is being knocked out when we compare wake, mild sedation, and unresponsiveness, patients not answering simple commands, and then recovery. It is not the primary sensory areas. We see here on the slide the visual areas, and they still do show activity, or the auditory areas. These to me are slave systems, necessary but not sufficient for you to actually be aware of your environment. We basically had similar observations in hypnosis, and we of course will hear much more about that in the lecture by Dr. Villas. But when we did hypnosis, and we have more than 10,000 patients in our university hospital who underwent surgery while laying eyes closed but awake, thinking about pleasant autobiographic memories. So this called so-called hypnosedation. And I'm one of the patients actually of the 10,000 plus database. In the fMRI, we would see a breakdown of connectivity in the external awareness network. So this is a kind of absorbed, dissociated state where we have less external awareness, and in neuroimaging we see that translated by a breakdown in functional connectivity. Okay, back to the patients and the added value, as mentioned, of doing these studies, because consciousness can be tricky. When we try to measure awareness, sometimes we can get it wrong, and actually we get it wrong. We've shown in a paper a couple of months ago by Aurore Thibault and Rajapanda that in 67% of patients clinically unresponsive, so their eyes wide open, but we think there's only reflexes, when we look at positron emission tomography and metabolic activity, we see, and this is coined MCS star, that there is more going on their brain and very probably their mind. We saw this also when we looked at high density EEG, and the analysis of Raja showed us these very nice mohawk functional connectivity images. The more threads, the more interaction between parts of the brain, and the more red, the more efficient. And we would see, of course, healthy controls, minimally conscious and unresponsive wakefulness, and minimally conscious state star, so only seen by neuroimaging, not at the bedside, indeed has a specific signature there. And very happy and proud, of course, that they made the cover of the Annals of Neurology a couple of months ago. We also see that there's a difference between structural brain damage. You see here voxel-based morphometry, so the structural damage in the brain, and how it impacts function. So positron emission tomography, I think, is one of the most direct measures when we use radioactively labeled glucose of synaptic activity. And you see here way more widespread metabolic dysfunction in the frontoparietal awareness networks, not visible on structural MRI scans. We also, through the hundreds of patients that we see in Belgium, sent by centers all over Europe, have the opportunity to follow patients over time who are minimally conscious. Here you see those who are minimally conscious minus on the left, and we don't understand why, what makes their capacity for neuroplasticity recover to minimally conscious state plus, remember, that is recovery of response to command, and how we see changes in metabolic activity. But there's a large heterogeneity. Minimally conscious state is like a waste basket. They're very different one from the other, and so are the functional damages. And also, when we try to understand the recovery, I think we need to improve our efforts because, of course, that has prognostic value. With functional MRI, we can also use artificial intelligence. We do that within the Human Brain Project, and apply these classifiers where the computer will tell us this is a patient unresponsive, this is minimally conscious, and we're now, through big multicentric studies, trying to use this as a predictor of outcome. This is again work by Rajapanda, who shows the importance of fMRI functional connectivity. This is a very, I think, beautiful representation of the interactions going on in our brain and the different networks right now. What happens when we are in unresponsive wakefulness and we see a breakdown of integration and information, and then minimally conscious state being in between. This is also what he published with our colleagues, Lopez Gonzalez from Barcelona. Without going into the details, you see both in patients, you see here the controls, minimally conscious, unresponsive wakefulness, integration measures, segregation measures, but also when they apply this to our anesthesia data, you would say this similar observations of when awareness is gone, so is the capacity of the brain to integrate the information. Now, with fMRI, we can also try and access consciousness when we do see that there are some minimal signs of consciousness. And that is the paper in the New England of now over a decade ago, where we showed a patient sent to our center in Belgium with the label vegetative state. Put him in the fMRI. We ask him questions like, imagine to move, imagine to play tennis. We're not looking at the movement, but we're looking at the activity in the motor cortex. And then we could move it further and actually show that the patient answered simple commands, not by talking or by a nonverbal response to command, but purely by decoding his brain activity. And that's also what we do with EEG, so-called brain-computer interfaces, by all possible means, trying to give some of these patients a voice. And it matters because, as said, and this is a paper from Lancet a couple of years ago, where the team showed that when you have those surprising results on neuroimaging, these are the patients that show a higher capacity for recovery. And why is that happening? We don't know. One of the theories is the homeostatic synaptic homeostasis hypothesis from Tononi, which we again challenged with high density EEG during sleep, and you would see these traveling slow waves. Actually, we would see them only in minimally conscious state. Well, we also saw signs, we believe, of REM sleep. Very hard to apply the criteria, and of course, impossible to ask them, were you dreaming? Because they can't communicate. But their EEG seems to show the eye movements, the lack of muscle tonus, and the EEG changes, but again, challenging given their baseline. When we have patients who recover, we try to understand what's happening, what is reconnecting there. A very old paper now from 2 decades ago, where we could show that there are these thalamocortical reconnections. Actually, within the thalamus, the non-specific intralaminar areas, which are exactly the ones that Nicholas Schiff a couple of years later stimulated, and the first case published in Nature. So really increasing our knowledge permits to improve the care after severe brain injury. Now, with our team, we've been trying, and this is the team of Aurore Thibault, to apply non-invasive electrical stimulation, TDCS, transcranial direct current stimulation, vagal nerve stimulation. So a lot of papers, you can see them here and find them on the website, or send us an email if you want more information. The team of Olivia Gossery is using pharmacological clinical interventions, amantadine, zolpidem, very interesting. This is a GABAergic sleeping pill, and it awakens some of our patients. And what she's currently trying is called apomorphism, where you see that there is, in some patients, but with reason to remain optimistic, clinical change, definitely an increase in brain metabolism, as you see here on the slide, measured by PET, and again, Rajapanda's high density EEG connectivity changes applying the method of Shrivas from Cambridge. So very, very interesting how these neuroimaging studies are changing our paradigms, our way to understand chronic disorders of patient consciousness. And it really matters, because as soon as you have a patient you thought was unconscious, previously coined vegetative state, now unresponsive wakefulness, you would basically treat them as such. They are, by definition, unable to feel or experience anything, right? And yet, many, as shown, are in reality in a minimally conscious state, meaning, as we have shown, that they can perceive, that they can also experience pain. This is a study where we applied noxious electrical stimuli in healthy controls, activating the whole pain matrix. They would say that hurts. It goes from brainstem, thalamus, primary somatosensory cortex, all the way to the affective cognitive network with the anterior cingulate and the insular areas. And the same network would activate in patients who can't express, who can't say, I feel pain, but their brain scans do. As you see on the lower panel, minimally conscious state patients activating the pain matrix, and very probably we should give systematically analgesics there. And that, I believe, just is one of the ethical consequences of this fascinating research, trying to understand consciousness, because it matters, because we can translate it to our clinics. Now, neuroscientifically, we don't understand our thoughts, perceptions, and emotions, yet we do see that there is this frontoparietal external awareness network, internal awareness network, critical for the little voice in your head. And we could see human conscious awareness as an emergent property of that collective thalamo-frontal global workspace neural network dynamics that we try to capture by all possible means, then to translate into diagnostic use, reduce this uncertainty. And it's important because we saw 67% misdiagnosis, to reduce the prognostic uncertainty, and of course, to translate it to novel therapeutic possibilities. So very fascinating to see how the old paradigms have been challenged, how event-related potential fMRI is revealing subclinical command following, challenging the diagnosis of what we called vegetative, now unresponsive wakefulness. And how these technologies actually, through brain-computer interfaces and real-time fMRI, is giving communication not dependent on motor pathways, giving these patients a functional communication. So I thank you very, very much for your attention, and just wanted to mention one thing, and that is we are not in a position to explain consciousness, so we should have a very open mind in this, including to look at very challenging topics such as near-death experiences. So this is an invitation to all our friends in India. If you know anyone who had a near-death experience, please contact us. We have now thousands of testimonies. This is just one graph showing that most of them experiencing as something absolutely peaceful, many also out-of-body experiences, and yet we are unable to explain the phenomenon. So would be very happy to interact with you and also look at maybe cultural differences in this, what I believe, universal physiological reality that is challenging our views of consciousness. So thanks to the team and the arrow pointing to Raja for giving us the tools, understanding human consciousness, one of science's biggest mysteries. Thank you so much.
Thank you so much, Steve, for giving this wonderful presentation from your own studies. You have very comprehensively discussed all details pertaining to discuss about the neural correlates of pathological states, the consciousness from a pathological states using various approaches, various very elegant designs, using PET, MRI, EEG studies. And also you try to study even the plasticity and also the possibilities of neuromodulatory approaches like TDCS or even vagal nerve stimulation or even pharmacological approaches, whether you will be able to get back the functional integrity in these states, pathological states, especially vegetative as well as minimally conscious states. Thank you so much. It was a real lucid presentation, and thank you for sharing all the information. And
thank you.
Your young students, your team, of youngsters. Very nice meeting them. Thank you. So we will get back to you during our discussion. You please stay on. We will move on to the third speaker. Shall we? The third speaker is from our own institute, Dr. Ganesh Kamath. He is a professor, Department of Neuroanesthesiology and Critical Care, NIMHANS. He's a very young professor, and he has got more than 10 years of experience in NIMHANS. He has done his MBBS, MD, DNB, DM, and he is also currently doing his PhD with McMaster's University. And he is also Secretary, Indian Society of Anesthesiologists, Bangalore Metro and Karnataka State branches. He has immensely published almost 135 scientific publications, 8 book chapters, 6 research grants, and he has attended many conferences, and he has provided many invited lectures. And he is also an editorial member of many journals. He has been bestowed with many prestigious awards like ISA Proficiency Award in 2018 and 19, Best Poster Award, ICMR International Fellowship in 2016, ISA Young Anesthesiologist Award in 2013, and so on. So it's my pleasure to invite my own colleague, Dr. Sri Ganesh Kamath, and to deliver the talk on anesthesia and consciousness. Over to Sri Ganesh, Dr. Ganesh.
Thank you, madam, for the kind introduction. Okay. So after listening to 2 excellent talks, one on anesthesia and consciousness and one in coma and consciousness by 2 eminent speakers, I am a little overawed by the presentation and would like to keep it as simple as possible and discuss some of the aspects from my perspective. There is likely to be some overlap between what is already presented, so kindly excuse me for that. At the outset, let me inform that I have no experience or expertise in philosophical approach to mind, brain, and anesthesia. So what I will be doing is discuss the evidence and our experience related to anesthesia and consciousness. I have no conflicts of interest to declare. So this will be the brief outline of what I will be speaking. I will just take you through how anesthesia has evolved, certain definitions, some of which are already covered by Dr. Stephen, and focus predominantly on sharing our experience at NIMHANS on brain connectivity changes with anesthesia, monitoring of consciousness and anesthetic depth during surgeries, and lastly on the anesthetic requirements in normal and pathological brains and in disorders of consciousness. Many of us do not know how patients felt during surgery before the advent of anesthesia. So, but what was described in the books is that it was very painful, very traumatizing, and many patients deferred their surgery, which were critical in nature, simply because they could not withstand the trauma of surgery. So on 16th October 1846, there was a first public demonstration of anesthesia by W.T.G. Morton, and which is currently celebrated as the World Anesthesia Day. And this was for a simple excision of a lump just below the jaw. And that has revolutionized the conduct of surgeries. And today in Bangalore itself, we perform more than 2 lakh surgeries under anesthesia every year. And rightly so, the advent of anesthesia was considered as a milestone, the third most important milestone by the BMJ readers after sanitation and discovery of antibiotics. And since then, the technological advances in anesthesia, monitoring, and surgery has revolutionized our practice of surgery and anesthesia, which offers a significant relief to patients seeking surgical interventions. The definition of consciousness, as Dr. Stephen has already mentioned, varies, and what is simple to understand is that it is a state of being aware and responsive to one's surroundings. And anesthesia is at the other end of the spectrum. The Alkay described anesthesia as a drug-induced, reversible depression of central nervous system, resulting in loss of response to and perception of external stimuli. So in modern anesthetic practice, it includes a triad of analgesia, muscle relaxation, and unconsciousness and amnesia. So it's not just the loss of consciousness, but there are other components to anesthesia as well. Now, if anesthetic drugs such as propofol is administered in 100 patients, it is likely that all 100 patients attain a state of anesthesia that is a guaranteed endpoint. However, the precise mechanism of how this anesthetic state is achieved remains unclear despite several decades of practice of anesthesia, and some of the hypotheses have already been discussed by Dr. Bala. For me, I look at it from this perspective. Awake state moves on to a more physiological sleep state, and pharmacological intervention, that is anesthesia, and the pathological alternation of the conscious state, that is coma. And as anesthesiologist, especially working in a center like NIMHANS, I am familiar with the interventions that are required for each of these states. For example, we use the drug called dexmedetomidine, which mimics closely with the sleep for providing sedation for diagnostic imaging like MRI, and we do about 3,000 to 2,500 such interventions every year at NIMHANS. Similarly, when it comes to providing anesthesia for surgical procedures, we again have immense experience in providing variety of anesthetic techniques and agents for surgery. Maybe we do around 6,000 neurosurgical procedures every year at NIMHANS. So that clinical experience helps us in tailoring our requirement to particular pathological states. Lastly, we manage patients in the intensive care unit, ours being a monospecialty, predominantly dealing with patients with disorders of consciousness. We see different states of consciousness to unconsciousness states in the intensive care units of different etiological basis, such as hypoxia, traumatic brain injury, neurovascular disorders. So with this management of patients of different categories, we are inclined to explore and understand the consciousness states better, and that is why our interest has evolved in this particular field. But when it comes to anesthesia, does the brain completely shut down? Now, that is the common question that is being asked by most of our patients when we discuss with them about anesthesia in the preoperative period. And we try to explain them in simple terms as it depends on the anesthetic drug, the dose that we use. We can have a different state required for particular surgeries. And in a simple way, this particular table gives you an idea about how anesthetic drug produces different state of consciousness, disconnected consciousness, and connected consciousness. And this is dependent on the mental content, sensory processing, purposeful response, memory, and likewise. So that provides a comprehensive understanding of different drug-induced loss of consciousness. Now, there are several tools which have been used for understanding the anesthetic effects on the brain. Of which more popular are functional MRI, the PET imaging, and EEG. And despite all these, there are some questions that remains unclear or unanswered, such as exact identification of the neural substrate of consciousness, differentiation and detection of conscious states in unresponsive patients, interaction of different anesthetic agent, hysteresis phenomenon during transition from consciousness states, anesthesia, recovery from anesthesia, and induction of anesthesia. And finally, mechanism of cognitive alterations during and after anesthesia. So there has been considerable progress in exploring the brain function, and that has allowed us to explore and understand neural correlates of consciousness better. And some studies which have been published have predominantly looked at functional brain connectivity, conscious network topology, and spatiotemporal dynamics between different brain regions and their interactions during anesthesia. With the background that we have, which I just informed, I was interested in exploring the mechanisms of anesthesia with help of imaging. And we have an excellent neuroradiology department here and Department of Clinical Neurosciences. And one of the person who was involved has been working with Dr. Rajnikant Panda. He has also helped us in analyzing the fMRI data and interpreting it well. So this was one of our earlier studies which we conducted, where we looked at the effect of anesthetic agent, that is propofol, which is commonly used for inducing anesthesia day in and day out. So we focused on the default mode network, which constitutes the PCC, that is posterior cingulate cortex, median prefrontal cortex, and the parietal cortex. And we compared the awake state with the anesthetized state in 14 patients with chronic back pain. We used we assessed the functional connectivity using bold signal, using resting state functional MRI technique. It's important that you maintain the cardiorespiratory parameters stable, that is within 15 to 20% of the baseline or the awake state, to avoid the influence of blood pressure and carbon dioxide on the blood oxygen level dependent signal, and truly reflect the effect of the anesthetic drug on the bold signal. So we observed that the connectivity changes were similar to what was documented earlier in healthy volunteers. This is our finding. We observed that there were significant reduction in the connectivity in different areas of the brain with that of PCC with propofol sedation as compared to the awake state. The top panel is the awake state and the bottom panel is the anesthetized state. When we looked at the specific area, Dr. Bala mentioned about the role of thalamus in anesthesia, and therefore we explored this specific region of thalamus and its connectivity with the default mode network. And as you can see from the box plot in the upper panel, there was an increase in the connectivity as compared to the awake state after propofol sedation. Modest increase was observed for connectivity between the thalamus and the medial prefrontal cortex. So what explains these findings? So the reduction in the functional network in the entire brain could be attributed to the metabolic suppression that anesthetic agents achieve, which proportionally reduces the cerebral blood flow, and this leads to the reduced activation of the regions which were active during the awake state. But we also found that there is some increase in the connectivity between some areas of the brain, that is thalamus and the default mode network. This could be explained by the following, that is random connections across the entire brain would have been smoothened. there are some inhibitory influences which are at play in the awake state, and this might have decreased, resulting in increased connectivity between thalamus and PCC and MPFC. And our patients had chronic back pain as a history, and so reduction in pain perception after anesthesia could also attribute to the increased strength of connectivity. And lastly, anesthetized state involves less processing of the brain and therefore could have resulted in a more slow and stereotypic firing pattern, resulting in the increased connectivity. So these were some of the reasons which we postulated to what we observed in our study. The same data set was analyzed for dynamic local connectivity by Dr. Rose and Rajnikant Panda. And I will not go into the details. What they observed was, what we observed in this particular analysis was that anesthesia reduced cortical fluctuations, especially in areas connected to default mode network and around the perirolandic cortex. Whereas there was increased dynamic local connectivity fluctuations in the deep nuclear regions such as thalamus, basal ganglion, and insula. So both these studies helped us advance our understanding of anesthesia-induced consciousness. It also supported the concept of consciousness as a dynamic integrated network rather than a single particular mechanism of action. So these are the findings. On the left panel, you see the awake state connectivity. The center, you see the sedation state, and then the difference between the sedated and the awake state. The areas which are highlighted in red signifies the increased connectivity at the thalamus, basal ganglia, and predominantly in the default mode network and the perirolandic regions. Whereas, in the basal ganglia, thalamus, and cerebellum, that is what you find here. Whereas there was the blue area, it shows the connectivity decrease in the default mode network. And these are graphically depicted as awake and assist. When you look at the specific areas, such in the default mode network, such as the pre and post central gyrus, the supplementary motor areas, TCC, you find that the connectivity fluctuations are predominantly suppressed after anesthesia as compared to the awake state. Whereas when you look at the deep nuclei, these local fluctuations are predominantly more active during the sedated state. Now, that is one way of looking at change in connectivity during anesthetized and awake state. There is also other tool which we can use to assess the changes, clinical changes in the anesthetized state using the EEG. And this was again informed by Dr. Bala in his lecture, where how the frequency changes over a period of different anesthetic depths from high frequencies to the more less frequencies, and then finally isoelectric EEG with increasing depth of anesthesia. Now, if you look at the different anesthetic agents, all of them do not behave similarly. There are certain agents such as propofol, which is classically studied in previous studies. They provide a different EEG spectrogram, whereas ketamine results in dissociative kind of consciousness and anesthesia. And it is again different from drugs such as dexmedetomidine, which provides more physiological sleep-like patterns. And inhalation agents such as sevoflurane again have different impact on EEG at different concentrations that are used. So in clinical practice, when we anesthetize the patient, it is really difficult to apply EEG, especially more than 4 leads, as is 16 or 32 channel EEGs. And also anesthesiologists are not equipped to interpret the EEGs in their clinical practice. And therefore, there are other monitors that we use for assessing consciousness and anesthesia during surgeries. And these include bispectral index or the spectral entropy or the patient state index, which provide a numerical value from 0 to 100. And depending on the values and the EEG changes, these are all from the processed EEG derived numbers. And we can come to a reasonable conclusion whether the patient is awake, whether the patient is in a sedated state or in a surgical plane of anesthesia, or there is an isoelectric EEG. And there are sometimes some of the monitors do provide us additional information by integrating the depth of analgesia as well, so that nociception during surgery can also be captured and a combined scoring for depth of anesthesia and analgesia can be provided. There are other surrogate tools to evaluate change in consciousness levels by looking at the change in oxygen levels in the brain. On the left side, you see the cerebral oximetry, which provides you oxygen saturation in the brain, just like we have a peripheral pulse oximeter, which provides the peripheral oxygen saturation. On the right side, you have what is known as the transcranial Doppler, which provides cerebral blood flow velocity, which can be used as a surrogate marker for change in cerebral blood flow with different stages of anesthesia and in situations such as disorders of consciousness. So these are not based on electrical activity of the brain, but on other mechanisms such as oxygen level and in the cerebral blood flow. Dr. Bala touched upon awareness during anesthesia, so I will not go into detail. So some of these monitors which I described help in detecting awareness during anesthesia, and no patients want to remember the intraoperative events, be it pain or be it recall of the events that occur in the intraoperative period. So some of these monitors, as I mentioned, can help in preventing awareness, which is distressing for the patient. The other role of or the relevance of anesthesia in coma or consciousness state is where we induce anesthetic coma for a variety of reasons, mainly to reduce the cerebral metabolism and electrical activity in situations such as traumatic brain injury, ischemia, and when there is a situation of raised intracranial pressure due to neurological acute brain injury, which is refractory to other pharmacological and non-pharmacological methods. And lastly, it is important that we monitor the state of coma when anesthesia is used to induce the coma or the pharmacological or medical suppression of electrical activity. Next, a little bit about disorders of consciousness. Again, this has been extensively dealt by Dr. Stephen and his own personal experience with different modalities. He has evaluated disorders of consciousness. So I'm not going to touch upon this. But I'll share with you some of our work that we did in NIMHANS. Basically, we were curious to know whether the requirement of anesthetic drug is different in patients with normal brain and who have a structural brain pathology such as tumors. So in this particular study, we compared the requirement of propofol for induction of anesthesia in patients with brain tumors and patients who had a normal brain and who had come for a spine surgery. And we found that there was not significant difference in the propofol requirement, nor the time for loss of verbal contact, that is what we call as induction of anesthesia, between the two groups. Probably because the sensorium was intact, the conscious levels were similar between the two groups, despite they having a pathology in the brain. But this was one study which my Professor Uma Mishra had conducted some time back, where they looked at one of the processed EEG modality known as bispectral index in different levels of Glasgow Coma Scale, which is a representative of altered consciousness. So you can see that the normal value of bispectral index in conscious patients somewhere ranges between 90 to 100, and that corresponds with the GCS of 15. And as the Glasgow Coma Scale decreases, indicating a decreased level of consciousness, the bispectral index also significantly decreases. So we also have this difficulty in providing anesthesia in patients with disorders of consciousness. A patient with traumatic brain injury, GCS of say 6 or 7, how much anesthetic drugs should be used in this particular patient? Now, these patients sometimes come for surgery for...
Ganesh, you have 2 more minutes.
Okay, I'll conclude. To identify what is the appropriate dose, this particular study was conducted, and we found that as the severity of traumatic brain injury increases, the bispectral index or the monitor for assessing the conscious level showed a decrease in the bispectral index value. Similarly, the requirement of propofol was also lower with the increased severity of traumatic brain injury, and time taken for loss of consciousness, as we defined as BIS of 40, also was less in patients with severe traumatic brain injury. So to conclude, human consciousness is an enigma. States of reversible loss of consciousness are useful channels to unravel this mystery. The induction, maintenance, and emergence from anesthesia provide ideal conditions for studying phases of consciousness. Currently, EEG, PET, and functional other imaging modalities are used to explore and understand the changes in consciousness with anesthetic agent and also disorders of consciousness states. Thank you for your patient listening.
Thank you, Dr. Ganesh, for that very very sweet and short presentation for 25 minutes. You have complimented Dr. Bala by providing the basics, the brain activity associated with anesthesia. It is very useful, general information for the public. It is very, very useful for the audience. And also very nice, you have shared your studies to understand the role of anesthesia in consciousness, using patients with the chronic back pain, using Indian population. A very nice presentation. We will take up the questions at the end of the session. Thank you so much.
Thank you.
You stay on. Now we have come to the last speaker of this symposium, Dr. Bhaskar Vyas. As he has mentioned that, I will just read out his biodata. As he is sick and he doesn't have energy to speak, perhaps his wife will be speaking on his behalf. She is also a hypnotherapist, and she has been also working with him for the past many years. So I think Dr. Rekna Vyas will be giving the presentation on behalf of Dr. Bhaskar Vyas. Now, anyway, I'll be sharing with you his biodata. Dr. Vyas is a surgeon by profession, and his transition to study hypnotherapy was because of his studies and exposure to esoteric meditation practices of Hindu and Buddhist tradition. And Dr. Vyas, he is actually by profession, he's a plastic surgeon, a pioneer in the field by establishing plastic surgery unit at the Medical College and MS University Baroda. He has trained in Edinburgh and Hahnemann Medical College, Philadelphia. He is practicing plastic surgeon as well as a visiting professor at the MS University Department of Psychology, Baroda. He recognized the convergence between modern Western model of hypnotherapy and classical Indian traditions of yoga. Along with Professor Hrishikesh Jana, they were founder of Indian Society for Clinical and Experimental Hypnosis in 1976. A versatile scientific training have enabled them to advancement in the depth of understanding of Patanjali's Raja Yoga as well as Vajrayana practice. They collated with Ericksonian strategies for contemporaries yoga for application in psychological disorders as well as lifestyle diseases. They have published several papers in national and international journals. They have initiated in Vajrayana practice of Tibetan Buddhism. Their meditative practices are based on Patanjali's Yoga Sutra. The range of these study extend from J. Krishnamurti's writing, Zen practices, Kashmir Shaivism, and transcultural varieties of religious experiences. They, as medical doctors, are involved in spiritual aspects of healing art. These are scientific tools in the form of hypnotherapy. With over 40 years of persistent contributions, they have successfully removed the academic bias against hypnotherapy, and now there is general acceptance that is contemporary form of Raja Yoga. Over to Dr. Bhaskar Vyas.
Thank you very much, Dr. Bindu. I am Dr.
Thank you, ma'am.
Vyas.
Thank you. Yes.
And I am a gynecologist by profession, and Dr. Vyas is a plastic surgeon. The previous three speakers have talked so much about the science, and unfortunately, we have not been able to prove with all this equipment because this equipment were not available to us. And maybe that at the moment in USA, Wisconsin.
Can you, madam, can you on your video?
Video on. Huh?
Yeah, I think this is only video. Yeah, this only. Yes.
Is it all right, madam?
Yes.
So now there will be a little shift of paradigm where all the evidences that has been given by previous speakers is not possible, though we have all the clinical materials. Consciousness as life in hypnosis and anesthesia. Talking about consciousness, that consciousness enters at the time of conception, and when consciousness leaves the physical body, it is death. So this differentiation is necessary because now I am going to speak more about consciousness of the mind. This is the hypnoanesthesia which was done in a subject. You can see the needles that has been inserted in front of elbow and also on the cheek. Now here no drugs were utilized and the subject was put into the deep hypnosis. The below elbow, the part was anesthetized and you can see the 3 needles which were inserted without subject feeling the pain. And then this anesthetized hand was transferred to the cheek where again the suggestion was given and the needle was inserted in the cheek after the anesthesia was transferred from hand to the cheek. This is one patient that we did for the first time and then asked about her experience. And she said that she had not felt the pain and the anesthesia persisted below elbow till we dehypnotized and then the sensations returned and the blood flow also was better. After this, we have tried in a patient where there was 80% burns and it was not possible to anesthetize her. Here we used a different method of suggestion of pleasure and creative visualization, and the stuff was removed with the knife and partly skin grafting was done. As soon as the procedure was over, she woke up and asked for the cup of the ice cream. When asked and interviewed, she said that she has not felt any pain during the whole procedure. It is very well known to the Indian audience that Raman Maharshi, when he had sarcoma of the shoulder, he was operated in a sitting position, fully conscious, and he went into samadhi and the surgery was carried out. Now, unfortunately, all the scientific evidences that the previous speakers have given is not possible for us for the lack of all the equipment. Now, we will talk something about the mind. Now, mind has no matter, has no anatomical presence. So please do not mind the mind. Do not fight with it because it is a losing battle. Make it a friend and understand it. Hold the reins of the mind. It consists of psychic processes that are generated by the interplay of molecules. The molecules may be broadly termed as information substances. Brain as an organ of overall control of CNS exercises its differential role, beginning from prefrontal cortex to frontal cortex and extending all the way up to reticular formation and substantia nigra, that provides a matrix for different states of mind. Now, consciousness, as already has been told, further on now we are going to talk on what we call as a mind consciousness, that we divide into three parts. The conscious mind, that at the moment that we are communicating is 3 to 5% only. Subconscious mind is 4 to 6%. That is where we take little time to bring from unconscious to conscious level by going back in time, and that is 4 to 6%. So total conscious and subconscious mind is only 10%. Everything that happens during life, right from the time of conception, goes into unconscious and is stored in the temporal region as it is in the book. This has been proved by Penrose in 1962 when he was operating on a conscious patient on the brain in the temporal region. A pottery just touched and the subject started singing the song of 1955 because that was the site of his age of 1955. And then now so much of research is going on this part of the mind. Mind and ego, as has been described in the Western world, that ego, as postulated by Freud, is constantly striving to maintain the balance between irrational demands of it and restrictive commands of the superego. We mainly modulate unconscious mind in hypnotherapy. Indian philosophical context. Rishi Patanjali has described 7 states of consciousness, and as it is written by him, Saptadha Pranta Bhumihi Pragnya. Saptada is 7 states. The expression of consciousness with 2 distinctly different states. They are awake, dream, and sleep. These 3 states, all of us experience every day, in and out, where the mind is constantly present. The 4th state is termed by Patanjali is Turiya, which is equivalent to deep hypnosis. The hypnosis is mild, moderate, and deep, depending upon what we are treating. And as I showed about the anesthesia, the subject is in a deep hypnotic trance. And when there is little lightness or the 4th state of consciousness, then subject starts moving. When we take the subject to the deeper hypnotic trance, that is comes as 5th and 6th. And so continuously when the surgery is being done, subject is kept at the level of the 5th or 6th state of consciousness. While mind starts becoming dormant, it assumes distinctive features. Hypnotherapists makes the person experience the fourth state, while meditation is induced by person himself. Its neurophysiology is being studied in the past few years with various neurophysiological evidences as shown by previous speakers as EEG, functional MRI, PECs, etc. Indian philosophical content. Four states we have already seen and have partly described the fifth and the sixth stages as the depth of hypnotic trance. Though their characteristics differ depending on the state of deepness of Turiya, there are numerous techniques available for transition from one to the other. The seventh state is called as Samadhi. Now, to talk in language of Sri Aurobindo, he says that what moment experiences in Samadhi, age is toil to express. Here it requires little explanation. Because in Samadhi, or let's go back to the fourth state, what we talked about the mind gets completely quieted, sits down as a friend, does not interfere. And so, in the seventh state of Samadhi, there is no language possible because mind is not there. And so, to describe that experience is very difficult. And whenever we have asked a subject in the fifth or sixth state, they just say it was peace, or usually described as shunyata. Hypnotherapy is like putting the subject in Turiya. Hypnosis, when induced with a facilitator or therapist, is characterized by voluntarily giving over control to the hypnotherapist. The suggestibility is heightened so that there is uncritical acceptance of the suggested act. It is used for treating the ailments and should not be used to follow unethical commands. So, having explained before starting the process, there is a spontaneous faith for good and virtuous behavior. Any such virtue can be enhanced by a specifically designed program for an individual. Uses of hypnotherapy, deployment of phenomena such as regression to the past. This tool is being used to remove so many situations and conditions where gradually we regress them to the time of trauma. Later on, selective ablation of the memory of any traumatic event, and then the subject is brought progression to the present and then taken to the future with better purpose. Have the potential to generate a sense of pleasure and well-being that can be long lasting. We have at MS University established that this is likely due to upregulation of genes regulating melatonin metabolism. 30 cases in 2 institutions were treated and statistically analyzed and is being published in the Journal of Physiology. Thus, the subliminal state of the mind during hypnosis can be utilized with various hypnotherapeutic suggestions in trance to provide therapy for difficult to treat disorders with drugs and psychotherapy. They are phobias, migraine, IBS, even jarred relationship, pain, etc. In 1972, Simonton and Simonton carried out the study in the advanced waiting to die cancer patients.
Madam, you have 2 more minutes. You have 2 more minutes.
Yeah, thank you. Have programmed even cancer patients for helping their suffering and increasing longevity and even cure for more than 5 years. Now, just talking about the meditation, there is this done by various techniques and so much is available. And when Vinoba Ji was asked, when do you meditate? He said, I am in a meditative phase all the time and work through pranayama. There are various methods and individual develops their own method of meditation and taught maybe by the therapy. Well, thank you very much for the patient hearing. And this was absolutely a different presentation with Indian origin. Thank you very much for patient listening.
Thank you, Madam, for taking the pleasure of presenting the talk for Professor Dr. Bhaskar Vyas. Thank you so much for this presentation. And you have explained very lucidly various concepts on hypnosis, anesthesia, concepts on mind, mind and ego, Indian philosophy, Turiya, meditation, and some details regarding the usage of hypnotherapy in various disease conditions like cancer, migraine, IBS, pain. Thank you so much, ma'am, for explaining very clearly about these aspects of hypnotherapy. Thank you so much. Now, I think we have come to the conclusion of all talks. Now, this is the time for discussion. I think we have got many questions for Dr. Bala, Dr. Steve, Professor Steve. Neeti, can you read?
So there are a couple of questions. This is to Dr. Bala. The question is, we have come across vivid recollection of happenings in the OT by patients post-anesthesia from various sources. Would you like to, we would like to hear from you if any of your patients have had shared such experiences.
Unfortunately, yes. My own patient, when I started here almost 20 years ago, so she recalled almost the first 30 minutes of everything that went through in the operating room. So I would say that was unsolicited. She basically came back and told all the details of what happened in the first 30 minutes of the procedure. I would attribute that to probably there was a mismatch between her requirements and what was given. It was not because anesthetic was actually maintained and she broke through it. She was a congenital disease patients with mitochondrial disease, and she was a 25-year-old undergoing a lung surgery. So I did the procedure, and she was under TIVA because we couldn't give inhalation anesthetics because of predilection for malignant hyperthermia. So at the end of the procedure, she just completely said everything that happened in the first 30 minutes. Even though I thought I was giving adequate amounts of anesthetic in the OR, probably there was a mismatch. She also had a higher heart rate to begin with, like 120s to begin with. So there was no way that we could have figured out that she was awake with a basic cardiovascular hemodynamics. So 20 years ago, Even though there were BIS monitors, they were not used routinely because BIS monitors have their own set of issues. And there was no other brain monitor that we used. So we used only cardiovascular hemodynamics as our indicator of someone is awake or not. If they're pretty high to begin with, there's not much you can differentiate it from.
Thank you. Thank you for the response. This question is for Professor Steve. How do non-responsive patients deal with chronic pain, especially since they can't communicate physically?
Thank you for that question. It's obviously very, very difficult. Pain is a subjective experience, and if you can't communicate, it's a challenge for caregivers. So, as said, I think we need to be very careful and look for whatever sign of discomfort in patients, such as grimaces, such as heart rate, as we heard from Bala, and developed a couple of scales. So there is an nociception coma scale that the team developed, where we can reduce all those responses to a number, and that can help clinicians to administer painkillers, not to give too much, because again, it can make them less conscious, but also make sure that they're comfortable. And definitely, we really need to understand better the capacity of these patients, unresponsive, minimally conscious, on perceiving both negative emotions, such as pain, but also positive emotions and pleasure. So we've been looking how music, for example, activates functional brain connectivity. And I think that's also a big and important project to help us in understand in the end their quality of life.
Thank you.
Okay, thank you. By the time we read
there's one more question. This is again for Professor Steve. India has a rich culture of great yogis where they attain to Mahasamadhi, the state where they voluntarily leave the body. How do you explain this?
Well, the honest answer is I don't. And I don't think any scientist can claim to have an answer. I think I need to listen to the experts here. And definitely, I'm very happy that the field of meditation, which is very new to me, I think it's surprising that during my studies at university, neurology training, meditation was never mentioned, and all these yoga techniques, if anything, it was in a negative spotlight. And I think it's unfortunate, because that's what I explain in the book. It has helped me as a person. It, I think, made also our research way more interesting, and I can translate it back to the clinics. But I do believe that the question, and I should listen to the others in the panel, merits more scientific study. And I really am convinced that that's what we have seen through our very limited contribution in the Buddhist monks, and also within Mind and Life. But the interactions with Bala and Sadhguru, I think, are extremely exciting, and it's wonderful to see those two communities go in dialogue. But maybe the others have more precise answers on the question.
I wanted to add something that was my own personal experience. I don't know, at my own peril, I'm bringing this personal experience. So in February, I had a life-threatening event in my own life. So I had a cardiac arrest at home, and wherein they had to do electrical cardiopulmonary resuscitation and defibrillation at home. This was acute, on the spot. It happened within a few minutes, and luckily our 911 was right away within 2-3 minutes. And so they came in, and I was talking to them, and I said, hey, looks like I need to be taken to Beth Israel Deaconess Medical Center. I know a few people there. Can you take me? They looked at me and said, no, sir, you look like really in trouble. Let's go to the nearby hospital. So they took me to 20 minutes. We reached the nearby hospital. Later on, the description that my wife gave was they had to shock me at home. My body was flying in the air. And while I was going, I had no recollection of what happened. But when I was in the hospital, I heard my friend screaming at me, "Hey, I'm here." And then I don't feel my body, but I hear everything that he's saying. And later on, when they were looking at me and doing some procedures, it's a third person narration. Like I could tell them, "Hey, my lungs are flooding, give me some Lasix, do this, put me on ventilator, do that, do this." There was no suffering, there was no pain. It was a third person recount, a third person experience of the whole thing. I did not have dreams, I did not have any hallucinations. I didn't have anything that was just out of the ordinary, but the whole thing was impressive because it was just a third person experience. So I was blown away by that. For 48 hours or so, I got discharged from the hospital and came back. But that event basically makes me believe whatever you just said, right? Like you can probably get out of your own body, like with the Mahasamadhi states. I don't have any experience, but I personally have been taken to certain states by Sadhguru's presence. So I have no question about these, presence of these states that are real. We just need to study them more. I have no idea how to study them. I don't even know whether we have tools, but we have to be open, like Stephen says. That's one of the reasons I love Stephen. I spent some time in his lab, and he's so open, and he's our scientific advisory board member as well. So hopefully, there was a lot of skepticism when we were about to open this institute at Harvard, but with the help of Stephen, Emery, and a few others, we convinced them and we opened it. We told them that we will walk the path of science. We will walk the path of objectivity as much as we can, but we want to make sure that you don't discount these experiences as BS. So that was the idea behind it. Now that I had my own experience, I feel like there's a lot of truth to whatever has been said and whatever is happening.
Thank you. To follow up your response to earlier question, Dr. Bala, Dr. Vindhya would like to know if the recall the patient had of the first 30 minutes, was it out-of-body experience?
No, she did not. And I still, Stephen asked me about the near-death experience. So I also had something when I was in third grade. There was a scorpion bite, and there were 2 bites, and I still vividly recall what happened at the time. And that was a complete out-of-body experience where I was watching myself almost from top of the roof. So similar to what other people described. And later on, my parents told me that they didn't know whether I was going to survive, but it took me almost 2-3 hours after which I came back. So there are 2 events now that after which I'm still alive, I guess. So I'm really blessed.
Thank you. I can't see the question. Just one moment, please. Yeah, so there's another question for Professor Steve. As a meditation practitioner yourself, how do you understand how your understanding of consciousness has changed, if at all?
Thank you for that question. I'm definitely not practiced as I think most of you here are. I'm a beginner, but I enjoy it very much. And I started with yoga, and then through the meeting of Mathieu Ricard, later Dalai Lama, of course, the several retreats really made me appreciate the complexity of my own mind. And it's a shame I discovered it so late, and I believe it is important in our field. I started doing research in sleep, and I was very interested in dreaming, but my supervisor barely had any dreams, and I do think it has an impact. So that is why I want to experience and to be a guinea pig for my own experiments, both in hypnosis, meditation, but also when we would give drugs. I think it's the challenge to bridge our neurophenomenology with the neuroimaging technologies. If we fail there, we will be nowhere in reading out the results of those objective measures. So I'm really very, very happy, and I'm still, as said, learning.
Thank you.
I just wanted to have some discussion with all of you. This is one particular mention Dr. Bala, mentioned in his talk, that when he talked about anesthesia and its effect on consciousness to Sadhguru, he said anesthesia cannot touch consciousness. But as a scientist and as a medical profession, you all know that anesthesia affect the brain functions and leads to loss of responsiveness, we can say, or loss of consciousness. So is this due to our understanding on consciousness, are from different perspectives? Sadhguru may be thinking from the philosophical perspective or Vedantic perspective, whereas we scientists, we talk consciousness from a different perspective. It may not be the same thing what they consider the concept itself.
No, absolutely. So I should really thank Stephen when we had this conversation called Mind and Brain. So it's in YouTube and almost 1 million people have seen that. So these were the questions that we asked. Should we even change the definition of consciousness, right? For example, when we started the center, Sadhguru actually gave a quote. His quote for the center was, "Consciousness being the fundamental intelligence that crafts both body and brain, conscious planet is a way forward for all issues within and without." So that just gives an idea of what he thinks of consciousness is and what we are thinking of consciousness is. So I think we are looking at it as a wakefulness, only one aspect of it, and whereas consciousness for him is something totally different. So yes, it is philosophical perspective, but having seen what all he could do, I won't put anything past him. But we have our eyes and ears open. We want to see the term consciousness itself, is it correctly defined? I think Stephen is splitting that into many ways and trying to look at it, what awareness is and what wakefulness is. And you saw that in one slide where he had the figure. So I think the definition of consciousness, the way medical people perceive, is probably within the understanding is very primitive when we look at it from the philosophical point of view.
Yeah, it's true. Steve, can you add some more thoughts on this?
I fully agree. We are, first of all, studying something that is extremely important. And we heard from two experts also with Dr. Sri Ganesh how, it's a challenge to monitor consciousness, being it during anesthesia, in my field, intensive care and rehab. So it does matter, and maybe for too long we considered it too complex and we were kind of afraid of it. It was a taboo to study consciousness, and I think this is not good when we would do some form of censoring, and I don't think that there is any field where we could not go. Of course, and you mentioned we are scientists, meaning we will confront all the time what we think we understand with what we think we measure. But I'm very happy to have meetings like this, also to see people from very, very different backgrounds, because I enjoy much being in India and discussing this, where, your understanding of consciousness and awareness might not be identical to how we perceive it. And I think today we have seen wonderful illustrations of that. Also, the talk on hypnosis and this very, very extensive experience that again illustrates the power of the mind and is something we do not exploit enough. And I try to bridge with many others, I think, here around the table, our classical understanding and technology to, power of the mind, by some seen as alternative approaches. And I don't think they are alternative. I think they're just complementary. And I think we really can become better practitioners and become better scientists if we listen more one to another. So thank you so much again for putting this up.
Thank you. Sri Ganesh, what about your view on this?
Well, I mean, I have no experience with what Dr. Bala has experienced and regarding awareness as well. Maybe we don't interview the patients that systematically and that frequently in India. I think that is where we need to work upon to ask direct question, leading question. Most patients will not volunteer. I mean, in Dr. Bala's case, I think the patient volunteered the information, but that doesn't happen most often. And regarding meditation and the role in anesthesia, I mean, what Dr. Bala mentioned regarding or you mentioned regarding anesthesia does not alter consciousness, to quote Dr. To Sadhguru. Well, I'm not very sure because that's not my understanding. It may help in other ways, like it may modulate autonomic function, reduce the complications in the intraoperative period. But to equate that, I mean, to say that anesthesia does not affect consciousness, it is, at least in my opinion, not the correct way to, from scientific point of view, to look at it.
Yeah, probably our concept about consciousness itself will be different. We may have to have more and more dialogues with the philosophers so that we can design some more, studies to go near to that understanding of consciousness. Our understanding of consciousness is maybe just our experience and our awareness, whereas the consciousness, what they explain, is totally different. I think this particular webinar, maybe we will have to have more and more dialogues like this, so that we will be able to bridge the gap between the neuroscience perspective as well as the philosophical perspectives on consciousness. Madam, do you have anything to add into this philosophy of consciousness? How do philosophers view, or
we feel that what we are talking is at the level of the mind and its various stages, and what is said as to 7 states of consciousness. So it is mainly what we have talked is of the mind consciousness, and not what has been actual meaning of consciousness, that is being alive. So this is the main difference according to us. That therefore in the first slide I said that when we are alive, then we are conscious, and when consciousness disappears, it is death, while the rest all are 7 states of mind consciousness, and 7th is the shunyata, when mind is absolutely absent. And as it was mentioned, Ricard and Matthew, they all are working very hard on lamas, on various aspects of mind and its effect, and so much of work is being done, which we are now trying to explore and correlate with the mind consciousness. And I'm sure that study will bring about the difference between the consciousness and mind consciousness.
Very nice. Thank you, ma'am, for enlightening us on this, because we need to grow some more, in these philosophical perspectives of mind, and to understand the actual or the concept called consciousness. Thank you so much.
Yes.
So thank you so much. We had a wonderful session. We had a very nice interaction and very nice talks. We look forward to have more and more this kind of dialogues and interactions. We will be in touch with you all. Thank you so much. Thank you so much for your time.
Thank you, madam. Thank you very much.
Thank you. And thank you so much, participants. Thank you for making the discussion very lively. Thank you so much. Now our next session, tomorrow it starts on at 9:30. Tomorrow 9:30 we will meet. Thank you, Steve. Thank you, ma'am. Thank you, Bala. Thank you, Sri Ganesh.
Yeah, thank you. Have a nice day. Bye-bye.
Yeah.